started to have weakness in the left arm. Another patient with a similar story, a 60-year-old woman with primary progressive multiple sclerosis who's on a treatment called ocrelizumab, which is the main treatment that we have for people with primary progressive MS. Also complaining of just, worsening symptoms, cognitive decline, which continues to get worse over time despite the use of this medication. So when we take a look at the MRIs on these patients, these are two MRIs spanning over a 3-year time period in both patients. You can see that there's really not much change grossly when you're looking at the MRIs in terms of the number of lesions. If you count a little bit of difference of technique in patient 2, basically distribution in terms of the number of white matter lesions is relatively the same. Maybe a bit of brain atrophy that has occurred over that 3-year time period between the two scans. If you take a look at the radiology reports on both of those patients, these are clinical scans that I'm talking about here. The radiology reports essentially just read them as stable, no new lesions, no contrast enhancement. They don't really comment much on the atrophy, which typically is not commented on too much in the radiology reports. So these patients are worsening over time, yet the MRIs are sort of, being read as stable. So, what is it that's really going on here? And what's causing that worsening of disability? Before we can get into that too much, I want to just kind of quickly review clinically what it is that we use MRI for, the standard MRI sequences, standard clinical MRI acquisitions. What do we look at on them when when let's say a radiologist is putting together a radiology report, or when a neurologist like myself is looking at them for a determination of what's happening with a patient. So we take a look at T2 flare lesions, shown by this arrow here. We take a look at whether or not there's gadolinium enhancement, which is indicative of active blood-brain barrier breakdown. Take a look at the T1 weighted sequences to see if there's any areas of hypointensity indicating that maybe perhaps there's a bit more myelin loss and some cell loss in those areas. And then looking overall at the sort of global appearance of atrophy. So we actually can learn a lot from looking at standard clinical MRI. That being said, there are a lot of things that we think that we're probably missing. So this is a table from a histopathology paper that was describing a lot of aspects of the histopathology at autopsy of patients with multiple sclerosis. And the things shown by the green arrows, things like active white matter lesions, inactive white matter lesions, axonal spheroids indicating axonal loss and probably relating to overall neurodegeneration and atrophy. Those are probably all things that we can measure with those standard MRI sequences, at least either directly or indirectly. But there's a lot that we are not really visualizing with those standard MRI sequences. So if you take a look at the pathology that's described here, cortical lesions, we didn't really talk much about cortical lesions when I was describing those MRI sequences. Slowly expanding white matter lesions is another thing that is of interest. Inflammatory infiltrates in the meninges are pretty ubiquitous in multiple sclerosis, but are not really, described or visualized by those MRI sequences. Perivascular infiltrates in the normal appearing white matter. Microglial activation indicating some innate immune responses. These are all things, again, that are aspects of MS that are just not really adequately visualized with those sequences. Even when we talk about white matter lesions, the white matter lesions themselves are not all the same. So white matter lesions can have an active component, and that's usually when it's a brand new lesion and it's going to have active breakdown of the blood-brain barrier. But those active lesions can transition over time into being either inactive, so not having any, continued active inflammation going on, or can become chronic active, where there's slow, continuous inflammation within the lesion or at the edge of the lesion that perhaps slowly expands it over time. This is kind of a cartoon version from a nice review paper from the New England Journal of Medicine showing some aspects of MS pathology. So lesions in the cortex probably are occurring in perivascular areas, so vessels in the meninges, and related inflammation in the subarachnoid space and at the peel surface, triggering some surface demyelination, microglial activation, macrophage, and T and B cell activity causing surface demyelination and neuronal loss. And then again, all white matter lesions are not the same. There have been 3 different sort of subtypes of white matter lesions that have been described, even at the acute stage, some of which have preservation of oligodendrocytes, some of which have apoptotic changes to oligodendrocytes, some of which are very cell-mediated immunity with T-cell infiltration, and others which are much more activity from antibody and complement. And then those lesions can go on in their lifetime to either, progress to being this kind of chronic, active, smoldering lesion, or just be left as a chronic, inactive, demyelinated lesion, or have remyelination that occurs. So a lot of heterogeneity to the pathology that perhaps is just not really being adequately visualized. So to give you a little bit of an outline about what we'll be speaking about today is how can we apply some ultra high field techniques to perhaps get a little bit better of a measurement of these things in vivo. So we'll talk about chronic active white matter lesion visualization, blood-brain barrier breakdown measurement, visualization of cortical and deep gray matter lesions, and meningeal inflammation. So let's start with chronic active white matter lesions. So again, what is a chronic active white matter lesion? Well, so the histopathology shows us that these chronic active lesions have a core, which is very heavily demyelinated. There's loss of oligodendrocytes, a very sort of hypocellular, apoptotic, and gliotic center. And then at the outer edge of the lesion, we see accumulation of macrophages and microglia. There's loss of myelin in the center, but there's some myelin debris in these macrophages, an accumulation of iron in some of these macrophages and microglia. And then evidence of blood-brain barrier breakdown with some vessels with fibrin deposition. These types of lesions are seen across the spectrum of patients with multiple sclerosis, but when you look, they seem to be more predominantly seen in the progressive, more sort of aggressive and progressive forms of MS. And if you look at the proportion of lesions compared to an MS severity score, you can see that patients who have had a worse outcome for their MS over their lifetime are more likely to have a higher proportion of this lesion type at autopsy. So some of the early work to try and visualize this lesion type on 7T MRI was done down at the NIH, and this is from one of their papers from 2011. And what you can see what they did there is they took a look at autopsy sections and stained those autopsy sections for iron stain, ferritin stain, and CD68, which is a stain that will be represented on macrophages. And you can see that there's this clustering of both macrophage-based inflammation and iron ferritin at the outer rim of a lesion like this. And when those lesions are visualized on MRI and a susceptibility sequence is acquired and processed for things like an R2 star map or unwrapped phase image, you can see that there's an abnormal signal, probably paramagnetic, at the outer rim of the lesion, probably due to that iron accumulation. So it's been speculated and confirmed a lot by this type of histopathology that we're able to visualize these chronic active lesions on with these kinds of MRI techniques. This was followed up a number of years later by another group at the NIH that showed similar findings with co-localization of the iron and CD68 staining in these chronic active lesions, the ability to find this kind of paramagnetic rim on the outer edge of those lesions on susceptibility sequences. And they looked retrospectively at the MRIs of these patients over their lifetime and found that those lesions that were destined to become this kind of chronic active lesion had sort of slowly grown and coalesced over the course of many years. They've also taken a look at this lesion type with the paramagnetic rim and looked at the evolution of those lesions over time and found that the lesions that have these paramagnetic rims have a tendency to increase in size over time. And lesions that don't have these paramagnetic rims have a tendency to stay relatively stable in size, maybe slightly decrease in size over time. And they also took a look at relating to those two disability scores and found significant relationships with the level of disability. So our group has taken a look at visualizing this lesion type using a different technique for post-processing, which many of you are probably familiar with, quantitative susceptibility mapping, or QSM. So this is a figure from one of our papers, and what you can see here is the flare image, and this is from a 7T MRI scan on a patient with multiple sclerosis. The flare image on the left and the quantitative susceptibility map that was processed from the gradient echo images on the right-hand side. And you can see that you can pick up a lot of heterogeneity of lesions. I mean, all the lesions look essentially the same on the flare scan. They all have that hyper-intense appearance to them. But when you look on the quantitative susceptibility map, you can see all sorts of variations. For example, this lesion here, you can clearly see it on the flare, but it's just, not present. You don't really see, there's just iso-intense white matter on the quantitative susceptibility map. You have other lesions that you can see on the flare, you can see on the quantitative susceptibility map, but they just sort of look, sort of similar, hyper intense lesion. And then you have other lesions that have an appearance on the flare of hyperintensity, but when you take a look at the quantitative susceptibility map, you can see again this kind of hyperintense rim on the outer edge with an iso-intense core in the middle. We took a look at those lesions across the spectrum of patients in our 7T study and characterized the percentages of various lesion types on a few different post-processing techniques, R2 star, a phase frequency map, and the quantitative susceptibility map. And looking at the QSM, for example, you can see that there's, again, this heterogeneity of lesions. Not all lesions are the same. We found 6% of lesions had this iso-intense core with a hyper-intense rim. And if you think about that type of appearance related to the histopathology that's been shown for chronic active lesions, it's likely that what these lesions represent is a hyper-intense rim due to paramagnetic signal from accumulated iron at the edge, and then that iso-intense core probably representing some cell loss, oligodendrocyte loss, myelin loss, iron loss in the center. And then a higher proportion of lesions that just have that hyperintense core with no rim, probably representing just some myelin loss without much change in the iron signal. When you take a look at the proportions of patients in our study, proportions of lesion types in our study, excuse me, and compare them between those with relapsing remitting MS, which was shown in pink, and the secondary progressive and primary progressive forms of MS shown in the red, or patients with a lower disability score. The EDSS score is a disability scale that we use in multiple sclerosis versus those with a higher disability score in the darker blue. What you can see is that lesions with that pattern, that iso-intense, hyperintense rim, a much higher proportion of those are seen in patients with progressive forms of MS, much higher proportion of them seen in patients with a higher disability score. And you see sort of the opposite with just this typical hyperintense center with no clear rim on the outer edge of it. When you take a look at the quantitative aspects of those lesions, so R2 star, frequency, relative susceptibility, this is probably representing mostly the core of the lesion. You can see that those lesions have, in the progressive patients and in the patients with higher levels of disability, have a much lower R2 star value, indicating, again, probably a significant amount of cell loss and demyelination and iron loss. And a lower relative susceptibility value, again, in that same population. We've also taken a look across the spectrum of patients in our 7T study at some possible sex differences. So this is from another one of our papers, and we took a look at the difference between men and women with multiple sclerosis and their patterns on MRI, and found that in men, 16% of lesions had this hyperintense rim on quantitative susceptibility mapping, whereas only about 5% of lesions seen in women were seen to have that appearance. A man was almost 7 times as likely to have a rim on their MRI. And this is consistent with histopathologic data that has suggested that a higher proportion of lesions in men with multiple sclerosis, at least those who come to autopsy, are found to have that chronic active appearance in men. And further, there's been some work that has shown that lesion tissue in men are more likely to express estrogen signaling pathways that are related to expression of more pro-inflammatory cytokines like TNF-alpha, whereas progesterone expression is in a higher proportion of lesions in women, and that actually probably helps to mitigate microglial activation. This lesion type has also been looked at by some other groups in relationship to some PET ligands to try and confirm whether there indeed is a sign of microglial activity. And this is just from one paper that took a look at a relationship between these quantitative susceptibility map hyperintense rim lesions and associated TSPO PET, and found a higher proportion of them did indeed have a higher uptake of TSPO PET within those lesions compared to other lesion types on quantitative susceptibility mapping. So let's talk a little bit about blood-brain barrier breakdown. So blood-brain barrier breakdown is evident in all phases of MS, in all lesion types in multiple sclerosis. One of the ways that you can look at this is for staining for fibrinogen, which will be deposited in areas where there is a blood-brain barrier breakdown. And you can see that there's fibrinogen deposition that's seen in autopsied and biopsy specimens, really in all lesion types, those that are pre-active, active, chronic active, even to a degree chronic inactive lesions. So this is clearly a significant part of the pathology of multiple sclerosis. And there are a number of MRI techniques that have been utilized to try and quantify the blood-brain barrier breakdown component of MS. So of course, techniques like dynamic contrast enhancement have been used to try and kind of map out what the tissue permeability characteristics of multiple sclerosis are. And some groups have taken a look at, for example, the tissue permeability values within normal appearing white matter or in lesions, and have found that there is increased permeability in multiple sclerosis. Some have even applied some of these techniques to clinical trials and found that patients who over time had had changes in their permeability were more likely to have disability progression than those who did not. But one of the downsides to a lot of these techniques is they're very complicated, require a lot of complicated post-processing, a lot of complicated mathematical work to really interpret those permeability values. So are there some simpler techniques that we could use? One of the things that we've done in our study, in our 7T study, is taken a look at using the T1 maps that are acquired using the MP2 range acquisition technique on 7 Tesla MRI. So for those of you who are not familiar with the MP2 range technique, this is a sequence with multiple inversion times that undergoes some post-processing and can give you both a T1 weighted image and a quantitative T1 map. And it's very useful at ultra-high field, not only because it gives you those images, but there's some inherent inhomogeneity correction that is built into the processing, which is very helpful for ultra-high field. So we've done what we call delta T1 mapping. So what we're talking about here is, so if you take a look at the top, this is the T1 weighted sequence from a T1 weighted image that comes out of the MP2 RAGE. We've acquired the MP2 RAGE image, both pre-contrast and post-contrast. And of course, not unexpected, you can see just visually that some lesions will be actively enhancing with contrast. So you see a lesion that's hypointense on the pre-contrast T1 map, T1 weighted image. And then on the post-contrast T1 weighted image, that fills in completely with the gadolinium contrast agent. And that's due to that T1 shortening that's happening, which could be represented also on the T1 map. So what we did is we took a look at so here's the T1 map here, and we identified lesions on the T1 weighted images that did indeed have the contrast enhancement that was visible, and so that's shown in red, and then lesions that did not have any visible contrast enhancement, and those are shown in blue. And then we subtracted the T1 map from post-contrast and the T1 map from the pre-contrast acquisition to create these delta T1 maps. And you can see on the delta T1 map, not unexpectedly, there's a very large change in that visibly contrast enhancing lesion. But when you look specifically at all those non-contrast enhancing lesions, you can see a gradation of a delta T1 change shown by these heat maps here. And so if you look at the values here, not unexpectedly, enhancing lesions, if you take a look at the pre-contrast T1 in enhancing lesions compared to the post-contrast T1 in the enhancing lesions, you have a very significant change. So a delta T1 of almost a full millisecond in the visibly enhancing lesions. However, in the non-enhancing lesions, there is a significant change pre and post-contrast. It's about a tenth of a millisecond, but it's there, and there's a significant difference between pre and post-contrast, and that's in the non-enhancing lesions. When you look at normal appearing white matter, so areas outside of those lesions, you don't really see much of a delta T1 at all. In the cortical gray matter, there actually also was a little bit of a delta T1, although the magnitude was much lower. And when we took a look to see, is there any clinical significance to this delta T1 value in the non-visibly enhancing lesions, there definitely was. So patients who have a higher EDSS score, so again, indicating a higher level of disability, they had a larger shift in their T1, so a bigger, more negative delta T1 value in those patients. Patients with the more kind of disabling progressive forms of MS, similarly, a larger delta T1 in those patients. And interestingly, in patients who, we have some patients in the study who were scanned at the time of being on MS treatments and some that were scanned at times of not being on MS treatments. What we found was that actually the delta T1 value was larger in the patients who were not on treatment compared to those who were. And we were wondering, is that sign of a treatment effect? Now, hard to tell in this particular study because it's not a randomized treatment study, but we did a regression model where we tried to adjust for a lot of other demographic factors to see if those were confounding, and there did seem to be an independent relationship with treatment and the delta T1. Another group has in the Netherlands has also taken a look at a similar kind of concept using the MP2 RAGE sequence and creating these T1 maps. And they've actually acquired a couple of different T1 maps over the course of image sequence and used those to create these concentration curves, or you can even maybe say permeability curves over time from an early T1 map acquisition after contrast compared to a late T1 map acquisition with contrast. And they're proponing this technique as a way to get sort of basic, simple permeability measurements with a sort of shorter, easier sequence to process. So let's talk a little bit about cortical and deep gray matter lesions. So cortical lesions, lesions in the cortex are a well-known thing at autopsy in multiple sclerosis. So shown here is the histopathology of them. They seem to kind of come in three types. There's the leukocortical lesions. These are lesions that traverse both the white and the gray matter boundary. intracortical lesions, which are these very small little lesions, usually centered on a very small vessel within the cortex, and then more widespread subpial demyelination. These can be quite extensive. They can cover large areas of the cortex in patients with MS, as shown by these kind of cartoon figures here. So we've taken a look at to see whether we can visualize those lesion types on 7T MRI, and indeed we can. This is from one of our papers from a number of years back that shows the MP. This was actually MP RAGE prior to our use of MP2 RAGE. MP RAGE on the top and a MP flare on the bottom. And what you can see is that we can see all three lesion types: leukocortical, so those lesions that kind of are crossing white into gray; intracortical lesions, so those very tiny little lesions within the cortex; and then these more sort of widespread areas of subpial demyelination. In that study, we took a look at lesions in the cortex across the different MS subtypes and also compared to healthy controls. And what you can see is that the lesion count, barely see any in the healthy volunteers, but very many in the MS patients, and even more in the progressive forms of multiple sclerosis. And this is a breakdown of those by the different subtypes. And similar with volumes, barely any lesion volume in the healthy volunteers, definitely a significant amount in the MS patients, and a higher level of them in the progressive forms of multiple sclerosis. And when you take a look at the clinical significance of these lesions within the cortex, we found very significant correlations between the EDSS score, which is a general measure of disability in MS patients. These are the correlation values shown here with lesion counts and lesion volumes. Significant correlations on the order of what you see with brain parenchymal fraction, so an indicator of the brain volume or atrophy, and twice the magnitude, actually, what was seen for white matter lesion volume in the same patients. And in addition to that, we found that this particular lesion type, the leukocortical lesion type, was very significantly related to a lot of our cognitive scores. So this is a whole series of cognitive tests that were done in this cohort, and the leukocortical lesion count had correlations with the scores on all those cognitive tests. When you take a look at some predetermined definitions for cognitive impairment as determined by that cognitive battery, we found that those who are cognitively impaired had a much higher cortical lesion volume compared to those who were cognitively intact. And there was the log cortical lesion volume very significantly predicted cognitive impairment, even when adjusted for things like age and gender and white matter lesions, atrophy, etc. We've also visualized deeper structures and have described lesions within the thalamus in patients with multiple sclerosis in our 7T cohort. Shown here are some images from that paper, and we identified two lesion types of these kind of lesions right around the ventricular surface of the thalamus. This is on FLAIR, and this is on the T1 weighted image, and then these sort of circular lesions within the body of the thalamus. We found that those lesions, very similar to the cortical lesions, they're present in the MS patients, not really seen in the healthy volunteers, and much more significantly seen in the patients with the more progressive forms of multiple sclerosis. We found that the burden was increased in the progressive forms compared to relapsing, very significantly. And when we take a look at the thalamic lesion burden in comparison to some other aspects of MS on the MRI, we found that there was a very significant relationship between the thalamic lesion burden and different cortical lesion subtypes. But when you take a look at relationships with white matter lesion volume, you don't really see much of a relationship. So that possibly indicates that the underlying pathology that leads to deep gray matter lesions is very similar to what leads to pathology in cortical lesions, but is separate and distinct from what leads to the lesions seen in white matter. So the final topic I wanted to address is meningeal inflammation. So why do we care about meningeal inflammation and multiple sclerosis? Well, again, let's go back to the histopathology. So if you take a look at the histopathology of multiple sclerosis and you look at the meninges, we see actually that there is really widespread inflammation going on in the meninges in multiple sclerosis patients. Most of that inflammation is occurring around blood vessels in the meninges, so this perivascular type inflammation. It's really distributed very widely throughout the meninges in many patients. And in a subset of patients, you see these organized leptomeningeal follicles. And these follicles have an overrepresentation of CD20 staining, which is for B cells, but also for follicular dendritic cells and other underlying structural components that actually look like this is probably ectopic lymph tissue, so kind of tertiary ectopic lymphoid structures within the meninges, and these are distributed mostly in the neocortical regions, and often are distributed kind of in the areas of deep sulci. So leptomeningeal follicles at autopsy are seen in about 40 to 50% of patients with a secondary progressive form of multiple sclerosis. And those subjects who have that sign of a follicle on their meningeal histopathology, if you take a look at those patients in their lifetime and or their autopsy, you find that they have a greater cortical lesion burden. They have a more widespread distribution of meningeal inflammation. Those patients had an earlier age of disease onset. They had more rapid disability progression and an earlier time to death. So really just a more aggressive and progressive form of MS associated with these meningeal follicles. So is it possible for us to be able to image the meningeal pathology that occurs in multiple sclerosis? Well, the jury's sort of still out on this, but there are some ideas. So some of that initial work comes from other conditions. We know that leptomeningeal carcinomatosis, for example, or infectious leptomeningeal disease is seen better on post-contrast flare than you see it on post-contrast T1. And we know that if you look at just the standard post-contrast T1 acquisitions, if you think back to one of those early slides where I showed the standard acquisitions in MS, we don't see meningeal inflammation, meningeal infiltrates on the post-contrast T1, really just see changes in the white matter in active lesions, but don't see meningeal enhancement on post-contrast T1 images. Flare has been shown through some phantom studies to be 10 times more sensitive to small concentrations of gadolinium in the CSF space compared to T1. So given this knowledge, is it possible that a flare sequence post-contrast could provide the ability to measure meningeal inflammation in multiple sclerosis? So one of the first groups to show this was, again, from the NIH, and they showed this is not from an ultra high field study, this is a 3T study, but what they took a look at is this idea of post-contrast flare, and they did indeed show areas of gadolinium deposition in the meningeal space on post-contrast flare. They found this to be present in 25% of their subjects, a very small number, but some controls also had it. They found it to be slightly more common in progressive patients. The foci themselves were stable over years. They did have 2 subjects in their study who actually passed away, and they did autopsy work on those 2 subjects and showed that the areas that had been enhancing during the lifetime of those patients had perivascular lymphocytic and mononuclear infiltration, suggesting that, yeah, maybe actually this is related to meningeal pathology. We've taken a look at this on our 7T study using pre-contrast and post-contrast flare and creating these subtraction images and looking for areas of hyperintensity within the subarachnoid region. And we've described on these images 2 patterns of leptomeningeal enhancement. So this is the T1 weighted image to kind of give you some regional context. And so this is the region we're looking at on the flare. This is the post-contrast flare. And you can see leakage of contrast out into that meningeal space. We term this the spread fill patterns, these kind of amorphous areas of contrast kind of leaking out and spilling out into the subarachnoid space. And then the nodular pattern, which are these very small discrete nodules, typically kind of adherent to the peel surface. In our 7T study, we actually found this to be much more common than what was described at 3T. We found that 90% of our subjects actually had at least one foci, 76% had the spread fill, and 51% had the nodular type. If you take a look at the subjects who did have this type of enhancement compared to those who did not, you could find that with the spread fill type enhancement, that patients who had that type of enhancement had a smaller cortical gray matter volume, indicating an association between the spread fill enhancement pattern and a more atrophic cortex. And there was a direct correlation between the gray matter fraction and spread fill foci. However, there was no relationship between leptomeningeal enhancement and the white matter fraction or the white matter lesion volume, indicating that perhaps this is a special relationship of meningeal inflammation with cortical pathology that is not related to white matter pathology. We've also taken a look at these areas of enhancement over time. So this is a study that took a look at baseline, a 1 year and a 2 year scan. We looked not only at those leptomeningeal patterns that I was talking about just a moment ago, but also some more sort of dural and venous type patterns with hyperintensities right outside the vessel wall, shown kind of here, and nodules within the dura itself, shown here. What we found was that for those venous and dural patterns, those are almost always seen on follow-up. The sort of leptomeningeal type patterns are seen at about 3/4 of the time on follow-up scans. And we also found that in those who do have persistence of those foci over time, those patients were the ones that were more likely to have disability progression over that same time period. We've more recently tried to make a direct comparison between a few different protocols. So this is some unpublished data. We're still working on this a little bit right now, but just wanted to kind of give you a quick idea of what we're seeing so far. With our newer acquisitions, we have a 3T scan that we're doing for comparison. When I say late versus early, what we're doing is we're administering the contrast and then scanning immediately after the contrast on 7T. With a flare scan, and then about 20 minutes later, again, a second time. So we have an early flare and a late flare. And then on our 3T scans, we're doing a similar about 20-minute delay for the acquisition of the 3T scans. And what you can see is that on 3T, all these patterns, the number of areas of enhancement that we're seeing on 3T are small. The number of areas that you see on the early version of the 7T, a little bit higher, and then the highest counts are seen on the delayed acquisitions, about 20-minute acquisitions of 7T flare. So what does all this stuff mean? It's hard to say. There's a lot of speculation here. One of the things that has been speculated is that what we're seeing is the consequence of meningeal inflammation close to blood vessels in the meninges. So we know that there are these inflammatory infiltrates within the meninges. We know that those inflammatory infiltrates probably are causing underlying damage to the underlying cortex through inflammatory cytokines, antibody deposition, complement deposition, and that's leading to things like oligodendrocyte loss, microglial activation, demyelination, and neuronal loss in underlying cortex. But those same cytokines are probably also causing local blood-brain barrier breakdown, recruitment of inflammatory cells, and if there's gadolinium in those vessels, that gadolinium is going to potentially leak out into the subarachnoid space. There's also been some speculation more recently that perhaps it's more just accumulation within perivascular spaces or within possibly even lymph structures. So there's a lot that we don't still know about this. But if you take that relationship as possibly being true, is there a direct relationship between this meningeal enhancement and the development of damage to underlying cortex? So the group up at Brigham and Women's has taken a look at this. They have a very similar acquisition to what we do, where they acquire an MP2 RAGE image and then pre and post contrast flare. And they took a look at the patients who had leptomeningeal enhancement on post-contrast FLAIR, and looked at the lesion status in terms of the number of cortical lesions and the cortical lesion volume, and found a significant association, a higher number of cortical lesions in those who had leptomeningeal enhancement, a higher volume of cortical lesions, and actually also some increases in thalamic lesions in those patients who had leptomeningeal enhancement. Interestingly, when we took a look at the same thing in our cohort, we actually found the opposite. We actually found no real relationship whatsoever between the presence of leptomeningeal enhancement and cortical lesions. So two papers, essentially saying opposite things. So an interesting thing, and we have very similar acquisitions and very similar analysis processes. We did in the same study, though, confirm what's been seen in our other studies and a lot of other studies over time, showing that these leptomeningeal enhancements are directly related to volume loss in the cortex, so cortical thinning, so atrophic pathology in the cortex. We've also taken a look at this relationship between leptomeningeal enhancement and possible neurodegeneration in a different way. Patients in our study are also, in addition to the MRIs, are also receiving OCT scans. So for those of you maybe who aren't familiar, OCT, optical coherence tomography, this is a technique that uses near infrared light shown through the pupil. That light scatters off the retina, and the scatter properties are reconstructed to reconstruct an image of the retina. And you can measure individual neuronal layers within the retina. And what we've seen in our study is that patients who have leptomeningeal enhancement, that's shown by the blue, compared to those who do not, which is shown in the red, those who have leptomeningeal enhancement have a thinner retinal nerve fiber layer in the macula and a thinner ganglion cell interplexiform layer in the macula. And in addition, if you follow those OCT scans over the years, the patients with the spread fill type morphology of leptomeningeal enhancement have a faster thinning of their macular retinal nerve fiber layer and also a couple of the other layers in comparison to those who did not have that enhancement, where their OCT values stayed relatively the same over time. So in conclusion, if we kind of bring it back to patient number 1 and patient number 2 and think a little bit about the fact that their MRIs were read as being, essentially stable, yet the patients are worsening. Why is that happening? Well, a lot of the things that we just talked about may be continuing to go on in these patients, and we may not be able to measure that with the standard MRI sequences. So things like chronic active white matter lesions, maybe slow, minuscule enhancement of those lesions within those patients, chronic breakdown of the blood-brain barrier and all of its potential consequences, accumulation of lesions within the cortex that we're just not really seeing or quantifying on their MRIs, and then the consequences of meningeal inflammation. So we think perhaps that neuroimaging methods for measuring these kind of chronic inflammatory changes and more subtle pathology within the gray matter are emerging and may be aided by 7T MRI. And these methods may help to redefine what it actually means to be stable for a patient with multiple sclerosis. And we think that 7T MRI and other possibly high field inspired techniques on lower fields may need to be integrated into clinical care and clinical trials for a better measurement of MS pathology and prevention of changes in pathology and multiple sclerosis. So before I wrap up, I want to thank all the people who have been involved in the collection of the data that's been shown here. Really, all this work couldn't be done without all the people listed here, and that this includes collaborations of multiple people within multiple departments here at University of Maryland, collaborators at Johns Hopkins, collaborators at the Kennedy Krieger Institute, and of course want to thank the sponsors of the various studies that were shown here, including funding from the NIH through those grants listed, the National MS Society and Bayer, EMD Serrano, and Genentech over the years. And I thank you for your time.
Thank you so much, Dan. This is a great talk as always. I learned so much. So now we have time for question and answers. As you can see at the bottom, you have a button called the Q&A. So that's the preferred method you can use for everyone including the attendees. I know you cannot speak, but you can use the Q&A to answer the questions. To ask a question, and we'll answer one by one. Or if you're not familiar with that, you can also use the chat box. But really, I think a Q&A is a lot better way to do that. So I guess to get started, then I want to ask one question. That was, as you know, I have a particular interest now for the, so-called the lymphatics and the lymphatics, hypothesis, if you will call it. So what's your thought on the relevance for MS, in terms of the lymphatics and lymphaticism some people are talking about?
Yeah, so it's a great question. We still don't really know. So I think that the techniques for measuring lymphatics are still, definitely being worked out. Some of the acquisitions and some of the methodologies that I've seen are, of course, require, the lymphatic system moves very slowly, right? So a lot of the methodologies that I've seen proposed require very complicated acquisitions, like possibly administering gadolinium and then scanning the patient, not only over the course of maybe hours, but maybe even bringing them back for later scans the next day and things like that. Measuring lymphatics maybe seems to be more practical. A lot of the same techniques that I showed in terms of the post-contrast flare, for example, there's been both some animal and some human work to suggest that a lot of those areas of enhancement around the blood vessels and around the dural sinuses are actually probably due to accumulation of gadolinium within the lymphatics. What are the implications for MS patients? I think we really don't know just yet. I mean, hopefully we'll be able to answer some of that with the data that we have. So with the data that we've been accumulating with our more recent study, which we're really only starting to work on the analysis for, does have, again, this kind of measurement over time. We have like the early flare and the late flare, and we can see areas of this sort of slow accumulation around those venous areas, around those dural sinuses, and we definitely hope to try and establish is that something that more it definitely happens in normal people. It happens more with age, so it's nothing that's unique to MS, but is it altered in any way? Is there going to be an alteration in the dynamics of the enhancement? Is there going to be alteration in the degree of enhancement? Don't really know just yet, but hope to try and establish that.
Yeah, thanks. So we have two questions in the Q&A. Dan, do you want me to read the question before you answer? Or
yeah, sure. Go ahead.
Okay, so the first question is, I'm wondering if meningeal lesion can be seen by non-contrast methods such as ASL. Okay.
So that's it's a good question. I don't know if that's been attempted. The areas of inflammation within the meninges are probably very small. So there's going to be limitations of resolution for sure. I don't know if an ASL sequence would be able to get down to the resolution that's necessary. I'm not as familiar with the sort of all the details about ASL, but I wonder if the measuring things on the arterial side will be as helpful. Maybe perhaps you also need to integrate some information from the venous side. Definitely what we see with these areas of meningeal enhancement is that they may not be present so much in the sort of arterial early component of the post-contrast images, and there's a very slow blood-brain barrier leak and very slow accumulation of gadolinium over time. So I wonder if things like that, or like a DCE sequence or a DSC sequence, will they actually pick up that both in terms of resolution and the time dynamics? I'm not sure.
Thank you. So the second question, how does delta T1 look in healthy people? Also in MS, any T1 change near meninges?
Great, perfect questions and stuff that we're starting to be able to look at now. In the paper that we showed that we did the delta T1 measurement in that cohort, we didn't have any controls. In our newer cohort, we have a whole slew of controls. So we will be doing that analysis of comparing delta T1 in controls versus MS. We have a clue probably though in the fact that if you look within the MS subjects that the normal appearing white matter did not really have a delta T1. So if you use that as somewhat of an analog for what may be going on in normal healthy people, then the delta T1 is probably unchanged. In terms of the delta T1 in the meninges, so that's a great question. It's something that we're hoping to do with our newer data. Also, right now what we're doing, which we hadn't done in the past, so those quantifications of meningeal pathology really have been more qualitative. So just counting the individual lesions. What we're in the process of doing right now is creating masks for those areas of meningeal enhancement, and then we'll be able to use those masks not only for volume quantification, but doing overlay with quantitative maps like a T1 map to determine is there actually a difference in the delta T1 in those areas. So to be determined.
Thanks so much, Dan. The next question from the chat box. Great talk. Do you think there is a killer application for 7T MRI in patients with MS? For example, that is, how might 7T MRI be moved into clinical practice?
Yeah, so the big question always comes up of how necessary is 7T to do all this stuff, it's a great question, and I think by no means is it absolutely necessary to use 7T to do all of these things. A lot of the techniques that I was showing have definitely been translated down to lower field. Now there are pros and cons, right? You're going to sacrifice potential for resolution. You're going to sacrifice like susceptibility effects, for example, on your susceptibility images. What's been shown, for example, with paramagnetic rim lesions is that if you compare the ability to visualize those on 7T compared to 3T, you're going to get a higher proportion of them for sure on the 7T compared to the 3T, but they're directly correlated with each other, and you visualize a decent amount of them on the 3T sequences that have been optimized, based on what's been seen at 7T. And so with that direct correlation, then if you're not necessarily visualizing all of them, but you're still getting maybe what's the clinically important information on the lower fields, then you can make an argument that you don't necessarily need the ultra high field. And I think that generally applies to all of these techniques, that I think that, yes, you can see and do a lot of this on the lower fields. You're just going to sacrifice a component of it. But, if there's enough of a correlation between the two, then maybe you can get away with it. But also don't forget that 7T scanners are now, at least the Siemens scanner is FDA approved. And there actually has been started to be the integration of those scanners into, at least at a number of academic centers, into the clinical workflow. And I have some colleagues over at, for example, at Harvard, at Brigham, where they are essentially scanning almost all of their MS patients on the 7T. It's kind of taking advantage of that higher resolution and the higher susceptibility effects. So over time, probably we're going to see more and more of that.
Great, thank you, Dan. The next question: could the 3D flare be optimized to show? Could the 3T flare be optimized to show the meningeal lesions better, or is it really something that requires a 7T?
Yeah, no, it's a good question. We're trying to answer that to a degree, but of course, I think a real thing what would have to be done is probably testing a lot of things in terms of optimization of different echo times and relaxation times, inversion values, resolution, etc. we tried to, in our study, in the prelim data that I just showed, we tried to kind of make our 3T acquisition and our 7T acquisition as close to each other in terms of the acquisition parameters as possible to try and eliminate things, related to the acquisition values. Now, what we couldn't do is have the resolution be the same. For example, on the 3T scan, that resolution on our flare is a 1 millimeter isotropic resolution, whereas the 7T is essentially a 0.5 millimeter resolution. And a lot of these areas are very small. So, whether it's a field thing, whether it's a resolution thing, I'm not entirely sure. But again, I think similar to a lot of the other pathologies, 7T is going to measure a lot more of it. It's not going to be exclusively seen on 7T, but you're going to measure more of these things on the high field.
Great, thank you. So next question from the chat box. Hi, Dr. Harrison, great talk. Have you found any valuable MR patterns regarding MS affect the optic nerves?
So optic nerve at ultra high field is a challenging one. There's a lot of susceptibility effects in that region that will make it extremely challenging. I believe that there are some people, I think some of the people down at Vanderbilt have been working on some coils that would be optimized for the optic nerve. And I've seen a little bit of stuff here and there on ultra high fields. So, I think the jury's still out in terms of whether we can even visualize the optic nerve very well on ultra high field. I mean, at the lower fields, what we see is that the patterns of optic nerve involvement in MS compared to some other inflammatory neurologic conditions indeed is different. Usually the MS optic nerve is affected in sort of small little regions of the optic nerve, whereas in, for example, a condition like neurosarcoidosis or neuromyelitis optica, you get much longer segments, greater than half or greater than 2/3 of the optic nerve involved when there's an optic nerve inflammation. But, again, it's something that you don't necessarily need 7T for.
Thank you, Dan. Next question. Hi, Dr. Harrison. My question may not be related to MS, but by using 7T during the acquisition, do you encounter any artifacts that may mislead your results, and how do you overcome that?
100%. So there are definitely some artifacts that are scanner specific, and a lot of the 7T scanners are I think probably pretty quirky, and you have to get used to the scanner and get used to the images that come off of them, and some of them are specific to probably to the field, or at least the way the coils are built for the field. And what we see is a lot of signal loss down in the lower brain regions that happens in various sequences. We see there are some wraparound artifacts occasionally that will occur that you have to deal with. So it's a great point. So what we try and do is this, we're used to the images at this point. We know the regions that we can't really, let's say, trust so much, and try and eliminate those regions from your analyses as best you can. It also comes into play in terms of doing things like brain segmentation and other sort of automated processes. So, a lot of the brain segmentation and skull stripping programs and things like that are designed for 3T applications or 1.5T applications, and pose a lot of challenges at the ultra high fields because of things like that, those areas of signal loss and some of those artifacts. So, we've had to do a lot of kind of like modification to existing segmentation algorithms, manual revision of segmentations. One of the grants we have right now is going to do a lot of manual work, but in the end, once all that manual work is done, is going to be using that to develop some machine learning algorithms for identification of various lesion types and some brain segmentation that would be more attuned to the quirks of 7T, I guess.
Great. I don't see more questions. Wow, that's a lot of questions, and this is a great discussion. I really enjoyed that.
All right.
So if no more questions, thank you, Dr. Harrison, again, for this great talk, and thanks to everyone for attending. I guess we'll see you next month. Thank you.
Thank you very much. Take care.
Thank you, Dan.